You are live now, sir.
Good evening. Welcome to this third episode of DOS Global web series. And this episode is on management of the basic corneal diseases and the corneal issues. So we have distinguished speakers, and all of them are cornea experts, and we'll start this session. And Dr. Bhalla, you can start the. Are you there? No, Dr. Prafulla.
Yeah, Dr. Prafulla, I think.
We can start the.
Yeah, so we have exciting the web series third in the line. First one we had was on cataract, then glaucoma, and this is very exciting cornea web series. We have lined up excellent speakers who are really going to cover up topics of great importance, or not only for general ophthalmologists, not only for cornea people, but also for general ophthalmologists. So Dr. Prafulla, you can take over and just start the proceedings.
Good evening, everyone. So we are going to cover three important aspects of corneal diseases today. First, we'll be dealing with microbial keratitis. The second section will deal with corneal ectasia such as keratoconus. And last one will address few common as well as advanced corneal surgical procedures. So the first section is about microbial keratitis. One of the challenges that most of our DOS members they face in private practice is managing a case of microbial keratitis. If you don't have an institutional backup, then how to approach that case? So our first speaker is Dr. Manisha Acharya. You all know her. Ma'am is primarily interested in eye banking and corneal diseases, and she is currently practicing in SROF Charity Hospital, Daryagarh. She will be speaking on how to approach a case of microbial keratitis in a private practice. Welcome, ma'am.
Thank you. Thank you for the kind invitation. And I thank you and the entire DOS for these web series. I'm sharing my screen. So is it visible now?
Yeah.
Am I audible? So definitely this is a vast topic of managing keratitis, and we will be talking about what to do in normal practice and in institutional, and what is the ideal practice of how we should manage. I've tried to concise management of keratitis to the actual need for a comprehensive ophthalmologist, and taken snippets of the cases of keratitis. So when this sort of a patient comes to the clinic, it is very normal to have it in a busy practice, be it institute, be it a private practice, or any clinic we are working in. We know we are dealing with keratitis. This particular patient was a 17-year-old patient with pain watering since 7 days. And since 7 days, and he was on treatment. It was not that the patient was not on treatment, on antibiotics, antifungals, which is usually normal in these cases. So what happens after that? One approach definitely remains is directly to start antimicrobials. Second is a systematic workup. I would just let you concentrate on systematic workup or approach, what it should be. History is very important. As we all know, we should know since when is the patient having a problem, or if there is any associated sac infection or conjunctivitis there. We have to know what are the symptoms patients present with. These are the usual symptoms any patient of microbial keratitis will present with. There are certain risk factors which makes them more prone to keratitis. They can be local risk factors of the eye or some systemic risk factors. If you look at keratitis per se, it can be divided into suppurative and non-suppurative. In this presentation, I will mainly deal on the infective keratitis, more so on the basic bacterial and the fungal suppurative keratitis. There are 4 stages at which a patient can present. It can be a progressive infiltration, an ulceration, a regression, and a cicatrization. Most of the time, the management may change a little bit, but not much. We may have to reduce the medications when it comes to regression, and at the stage of cicatrization, we'll stop the medications. For any practitioner managing it, documentation of the ulcer is important. Nowadays, we have good photographs which are there, but a painting is always better than a photograph. It can be more detailed and have definite size of what we are dealing with. Again, I go back to the same case that this patient was on treatment for 7 days. And when he came to us, as I said, was on antibacterial, antifungal, and antivirals as well. What we did was a microbial evaluation. It's a gamut of investigations you can do. But what is the most important here, I would say again suggest, is the KOH mount and a gram stain. And these two do not require a big setup of a lab. It is simple, small smears, which can lead to a lot of information, and immediately we can start the right treatment. The patient was found to be KOH negative, so no need for antifungals at that point. And their gram staining did show gram-negative bacilli. We started the patient, we stopped all medications the patient was on and just started on fortified antimicrobials, and the patient started to respond by 3 days, and later on had the growth of Pseudomonas there, with sensitivity pattern also there. And by day 9 and by day 13, the patient was doing well. And but within 2 to 3 weeks, that the patient did well. So the patient already was on treatment, but was not responding. What we did separately was just the scrapings, because it's important to know our enemy. We may not particularly know which bacteria or fungus we are dealing with if we do not have a big lab setup, but smears do help. I would just stress a little more on the KOH mount, because that's very, very important and very easy to do. And it is nowadays, with the pictures present, you can just even tie up with a local microbiologist or ocular microbiologist. It can be anywhere in India or the world. You can just send the pictures and get some reports. So immediately after smearing the material, we have to add KOH reagent and put cover slip. 92% sensitive and specific for fungus. Hyphae can be seen. Fungus can, most of the time we say, because of the specificity, it should be ruled out. But it can not just fungus, it can also identify acanthamoeba, nocardia. So if you have this setup, which is there in your simple lab, or in the OPD, this also helps. We can train a technician. We don't need to, as ophthalmologists, we may not get that much of time. Just training of technicians can also help. And this is found to be one of the papers which has really been made to understand that just a simple KOH mount can aid in the management of infectious keratitis. These are the pictures of gram staining. We can have several, and we can identify some of them. This gamut may not be available to all, but if all is available, we should go in for that. And we had this publication on the clinical microbiological profile and outcomes of infectious keratitis, which did reveal that bacteria still remains the most common cause of keratitis. So if we just go to some bacterial keratitis, the most common presentation in our clinics is usually pneumococcus. Because if there is any sac problem or sutures which have an abscess, the commonest cause is the pneumococcus. It presents as ulcer serpiginous. By that we mean one part is healing and the other is still extending. And the perforation is usually common in this case. But if identified early, they are very easy. They can be easily treated with fortified medications. And this was one of the suture infiltrate which had pneumococcus and did respond to medications. If you're dealing with compromised cornea, staphylococcus is something which really come up commonly, and they also respond well to fortified medications, and can post-graft also they can be there, and even in normal circumstances, especially in the hospital-acquired infections, staphylococcus is an important cause of keratitis. Pseudomonas is a virulent organism, and there is thick mucopurulent discharge, and melting of cornea starts early. So a little difference in the management may be needed over here. So when we deal with that, what we usually see is a big hypopyon and melt or central thinning, which is coming to us. This was one of the cases post CXL of keratoconus the next day, and did not look very, very healthy, as you can see. But simple scraping revealed that we were dealing with a bacterial infection. And even on the same day, within half an hour, we started the patient on antimicrobials, and the patient did respond. So these are risky situations. If caught in time, they do well. So rather than starting a combination, if we know somewhere we are dealing with a bacteria or a fungus, we'll be able to manage at least 70 to 80% of the keratitis. The rest definitely may need an institutional management. This was another patient who was referred for keratoplasty, and once I saw in the OPD, I also thought we may need a keratoplasty. But again, the patient was on a cocktail of medications, and as per a protocol, we did the scraping, and we did find that it was not showing fungus, but some bacteria. We later on found it was corynebacterium. But what we did, as a protocol, we took 24 hours to say that, okay, let's stop medications and put you just on the antibiotics and lubricants, and the patient did respond and did not need a therapeutic keratoplasty. Later on, an optical keratoplasty was definitely done. So how to manage these cases? Management remains, we have to understand that a specific antimicrobial agent will hit the bullseye. You give them a combination of antifungal, antimicrobial, obviously their understanding of a particular disease and the compliance also reduces. And the treatment has to be initiated based on smears without waiting for the results of cultures, even if you've sent. So smears are good enough for them. Initial empirical therapy, we have to start with on broad spectrum antibiotics with a loading dose if you feel it's important. And just combination mode of therapy is good. For smaller ulcers, the monotherapy does well. Combination therapy of cephalosporin along with aminoglycosides do well. For nocardia specifically, amikacin is a good eye drop for treating them medically, and they do respond well medically. This is one of the picture which is showing a ciprofloxacin toxicity. So sometimes when we see something like this, we do not realize it may just be the add-on, I would say medicamentosa because of antibiotics. The other important entity where we are dealing, because 43 to 44% are fungal keratitis, they usually have a grayish look and dry looking with stromal infiltrates and satellite lesions with immune rings. Sometimes just on the look, it's very difficult to say that we are dealing with a fungal or a bacterial, but if you look at these hyphatic edges and some sort of guttering, nowadays we say that's more of pythium, but also fungus also present with these hyphatic edges, as you see in the second picture up there. So this was one of the patients who had shown fungus on KOH, started on antimicrobials with debridement and 1 hourly natamycin, did respond within 2 to 3 weeks. And it came out to be fusarium later on. So the cultures will always come later. So it's always important that you started with smears. This was another patient who presented with keratitis, had a KOH positive and did grow fusarium and was started on natamycin hourly and did respond with the single therapy. Candida usually presents as a localized infection, usually in immunocompromised, they say, but it is still very commonly seen these days, and it does respond to antimicrobials. Natamycin is the most commonly used drug and the most effective drug for keratitis, but it comes as a suspension. So it is always better to change the drop within a week, tell them to get a new eye drops. Right now, we do not have very standardized natamycin preparation. And nowadays that yellowish color natamycin also comes. So we did some toxicity results in them and found that they did not have a lot of toxicity in, but somewhere the discoloration was happening. So the duration of treatment of fungal is more prolonged as compared to bacterial. Just a small mention of MUT trial, which compared natamycin with voriconazole, it was found that natamycin still remains the drug of choice for most fungal keratitis. The other trial of oral voriconazole also showed that there was no clinical benefit of adding voriconazole, which adds a lot to the cost of the to the patient to antifungal drugs. So it's still effective to use natamycin 1 hourly as vis-a-vis to these expensive drugs. Epithelial debridement is still one of the favored thing in fungal keratitis. It serves to debulk the cornea of the necrotic debris. Oral antifungals are indicated in large and deep ulcers only. You may not need it for smaller ulcers. Fluconazole, ketoconazole are usually used in most cases. LFT are very, very important. This was another post-LASIK case wherein we saw the patient was referred for this keratitis and was on medications, antimicrobials. But what needed in this case was flap was lifted and we did just cultured it, found it to be KOH positive, started on topical natamycin and the patient did respond. The assessment of keratitis has to be done by blunting of perimeters of infiltrate, reduction in the density of suppuration, AC inflammation reduces, there is reepithelialization which starts. So then we know that the ulcer is responding. Progression, if it is there, we may need to admit the patient or call them for very frequent follow-ups. This is the time when microbiology has to be done in detail, and it may, if in private practice it's difficult, can be referred to an institutional level. Corneal biopsy also does well, is an important indication in these cases, and other possible causes have to be done. If there is thinning and perforation of the ulcer, tissue glue and penetrating keratoplasty remains the options. This was another patient KOH positive. And finally, when a 1 week follow-up, it was just looking like it's responding, but suddenly has a perforation. And the surface lesion was better. A glue was done and the patient responded well post-treatment. This was another patient with KOH positive, but showing a lot of thinning. Here, we thought that it was some sort of a melt happening, did a tarsorrhaphy and kept on antifungals with lubricants, and the patient did respond with a scar formation there. Therapeutic keratoplasty remains a choice if the ulcer is progressing and is non-responsive to therapy or there is large area of perforation. Trephination should be large enough to include at least 1 millimeters of the surrounding normal cornea in these cases. If I'm exceeding, I may stop here, or I'll just have one more case if we are interested. Just taking to another segment of keratitis, sometimes such patients come with anterior and posterior segment of the other eye being normal. This was a very thinned out cornea, again referred for keratoplasty, but we see there is plaque formation with desmetocele and mid-stromal infiltrate. It was not showing a lot of infectious lesion there. So we did KOH scraping, and the few GPCs were seen, but other findings were normal. Again, patient was stopped of all antimicrobial therapy and started just on a broad spectrum antibiotic and tear substitutes, because what we were dealing here looked more like a medicamentosa. And repeat scraping also did not show any organisms, so we were sure we were not dealing with very fulminant infection here. And after 1 month of the broad spectrum antibiotic, the patient did scar. So how to judge and what to do for keratoplasty, I would just rush because we are dealing more with that. This was a fungal keratitis patient, and the B scan was normal. LFT is done for this case, and the keratoplasty was done. After that, you have to send the button for keratoplasty, which will show again reiterate what you were dealing before in the scrapings. Here it showed aspergillus niger, and histopathology reports usually they have to basically say which level of cornea was involved. It gives us a little clue. So these are some other keratoplasties done for them. I've just discussed this.
So I think you come up now.
Yeah, I think I'll just put a take-home message. We have to make the clinical diagnosis. A proper documentation is important, and indispensable role of microbiology is there, but simple KOH is going to take care of a lot of microbial cases at any practice, and be specific in treatment rather than giving broad spectrum treatment always. Thank you very much. And I again thank you for the opportunity. It was actually a very vast topic. I did not know how to cover it up in such a small time. So thank you again.
Thank you very much, ma'am. That was really a nice, comprehensive overview of how to manage the case of microbial keratitis. In the Delhi keratitis study that you published, Delhi infectious keratitis study, was there any difference in the trend that we have observed over last few decades, maybe? Because there seems a higher proportion of bacterial keratitis, almost 60%. But earlier teaching was that fungal keratitis accounts for almost more than 50% in Indian setup. Any other differences that you observed in that study?
So in the study, we had around 625 samples in a year. And what we found, definitely what you're saying, the trend of the infections, what we were been seeing, we compared it with the RPC study also, basically, and we found we were having similar trends. Now we are doing another study wherein we are comparing the two, one at the Delhi center and the other at we have a center in Mohammadi where there is a microbiology lab as well. So we will be comparing. I think that is going to be more relevant when we are talking about nascent patients coming to the hospital, because here in Delhi, sometimes they're usually pre-treated patients who are coming, and usual normal patients are getting treated by pharmacy. And, we're not seeing a lot of bacterial keratitis most of the time. It's not that there are less ulcers happening. You all will agree there. So that study did not show a lot of change in the trends happening. And basically, if you look at the North Indian study, it was pretty, the trends were quite similar to that of the RPC study.
Thank you, ma'am. So we do have a few panelists for this keratitis session. Welcome, Dr. Pranita Sahai. I think you are also practicing in one of the private corporate center in Delhi. So what's your take? Do we need to scrap all the keratitis patients, or if you don't have the facility, you can still trust your clinical skill and manage such cases? And when you are trusting your clinical skill, what's the point where one should refer a patient to the institute?
Yes, sir, exactly. That is the question I wanted to ask Dr. Manisha itself. That, ma'am, considering the medical legal aspects, what do you do? Do you scrape all patients, or do you keep a cutoff there to scrape these patients?
I scrape all patients unless they're too small or less than 2 millimeters, I say. I've also scraped a 2 millimeters ulcer and found pseudomonas growing in a contact lens induced keratitis.
Exactly. In the
So
morning
I would
today
say,
itself, in the OPD, I had a patient and a similar doubt. She was a contact lens user. She had a 1.5 millimeter infiltrate and epi defect. I was in double mind whether to scrape or just start her on topical antibiotics and wait. So ultimately, I took a call. I started her on topical antibiotics and I've asked her to review in 2 days and see.
I think that that's a very valid approach. If it's less than 2 millimeters and you're keeping the patient on close follow-up, then it's always better because most of the time contact lens induced is, if it's an acute problem, it's usually bacterial and the patient has not been on any medications. You are saying, even if you're dealing with a pseudomonas, it'll respond, because what we've seen is, if it's acute presentation, these are usually not resistant to a lot of antibiotics. But yes, follow-up is important. But on follow-up, even if one glitch you feel that it's not responding, I would suggest go in for scraping. And the smears are important. I mean, I always stress on that. Even if you do not have a big microbiology lab, simple KOH and grams, we'll be able to at least touch 70 to 80% of ulcers, because only 20% will have the atypical. And even if you're just doing a KOH and able to rule out fungus, that is a very good clue when we're dealing with keratitis.
So thank you, ma'am. I think, sir, Delhi has a fair amount of access to the ocular microbiology labs, and a lot of labs are dealing with ocular microbiology samples. So sending a sample of corneal scrape is not a limitation to, I think, any of the cornea specialists here. So definitely, if possible, we should definitely scrape all cases and send the samples to these labs. That is not going to be a limitation. Definitely. And I think corneal debridement is one of the most important treatment that we should give to these patients on every follow-up. That is something that we often miss out. But I think if we debride these patients on all visits and all follow-up, most of the patients would heal on medical therapy itself and will never require a therapeutic keratoplasty for non-responding corneal ulcer.
Thank you, Dr.
Yeah,
Panik.
debridement has to be done in fungal keratitis only, never in bacteria.
We have few questions by Dr. Gohar Ahmed from J&K and Dr. B. Karunakar from Andhra Pradesh. And these are related to degeneration dystrophy. So I think that is not relevant to your topic. So we'll answer that later on once the session is over. And so
Praful, I want
now,
to add one or two things,
yes,
if
sir.
you allow.
Yes, sir, please.
I think Manita did a wonderful job, taking entire, keratitis in such a short format and beautifully presented. In terms of risk factor wise, I think in our country, steroid use is one of the very, very important risk factor, which has to be highlighted to the common, practitioners. They should use steroids in a very judicious manner, because we see a lot of patients coming with the history of steroid use, especially younger patients. And other thing important is, sometimes we do a repeated investigation, but we don't get any culture or smear positivity. So these are cases which may have a higher chances of deterioration and may require a therapeutic keratoplasty in long run. And as Manisha rightly pointed out, Delhi, we see a lot of patients with a lot of treatment already on. Sometimes you may have to stop treatment for at least 24 hours, then do a scraping, you might get a positive rate also. And institution like ours, we do a lot of patients coming with a polymicrobial infection and sometimes mixed infection also. That has to be kept in the mind in cases which are not responding to your standard treatment. Thank you.
Thank you, sir. So now I request Dr. Bhupesh. Dr. Bhupesh, please invite our next speaker.
So the next speaker is Professor Vanati from RP Center, and Professor Vanati is a prolific cornea surgeon, and she has held many positions in All India Ophthalmic Society, like member scientific committee, member ARC, and in DOS also she was secretary and editor. And I invite ma'am to talk on extended utilization of corneal tissues. Dr. Vanati, please.
Am I visible and audible?
Yes, ma'am.
Yeah.
Yes.
Yeah.
Yes, Dr. Vanati, you're
Yeah.
visible and audible. Yeah.
Yeah. Thank you. So over the next 20 minutes, I'll quickly take you through the profile of donor tissue utilization. And I have no financial interest in mention of any of the products during the course of my talk here. So now we have currently moved from
Stay somewhere else only. No, not everybody can stay. No,
we have
halls are going to be there in the same place only. They were in Geo Convention
Mute,
Center.
please, mute.
Radisson
Mute,
Blu
please.
Yeah, so we have moved on from whole globe retrieval to in situ corneal scleral rim excisions today. And most of our keratoplasties are being served by this method of retrievals here. So penetrating keratoplasty still forms the chunk of keratoplasty here. And in India, I think knowing to do a good PK and a good follow-up PK is imperative to manage the several indications which still prevail in our practice, cornea practice here. And Manisha wonderfully highlighted the various scenarios which need therapeutic keratoplasty. So we move out from the need for optical corneal tissues, and we do utilize our non-optical grade corneal tissues for management of these various conditions which need to debulk the cornea of the infective organisms, so that we could probably give a tectonic restoration and take these eyes on for refractive procedures later on here. Peripheral MELs such as this being infective peripheral ulcerative keratitis or immune ulcerative keratitis, when they are extensive and cause such extensive tectonic thinning, will need reconstruction. And again, the use of non-optical grade tissue gets put to good use here for tectonic restoration of these ocular surfaces here. I think our subsequent speakers will be giving more detail into the nuances of the various keratoplasty aspects here. So I would just touch upon these, that penetrating keratoplasty still remaining a large part of keratoplasty procedures in Indian scenarios, but we have largely moved on to custom keratoplasties or custom replacement of the corneal tissue, the layers of the corneal tissues which are afflicted by a particular pathology, be it either posterior lamellar keratoplasties or anterior lamellar keratoplasties here. So the good point in anterior lamellar keratoplasties, the various types of anterior lamellar, be it big bubble DALK, a PT DALK, HALKs, SALKs, whatever, these put to good or effective use for refractive rehabilitation and visual rehabilitation of the non-optical grade tissues here. And the posterior lamellar keratoplasties and D6 and DMEX here, we need good grade optical tissues, preferably younger donors with good specular counts for performing these procedures in eyes with endothelial disorders here. So we now moved on from you doing D6 to DMEX, where we just replace the endothelium and the Descemet's membrane for a variety of early endothelial disorders here. So thus, there is a variety of indications for which we can use the cornea effectively here. And of course, PDEC has also helped us to use endothelial tissues in those corneas which cannot be cut with microkeratomes as well. When we look at other expanding indications, simple dermoids such as this is a dermoid excision with a lamellar graft with glue fixation. And here you have a good effective use of non-optical grade tissues. This is yet another case of pellucid marginal degeneration, an extensive one here, which needed a banana lamellar graft here for initial tectonic integration of the ocular surface before we could take the person on for visual rehabilitation in terms of lamellar keratoplasties. Another indication for use of non-optical grade tissues in our country is when we have post-pterygium melts such as this here, an extensive melt which warranted or would require the need of a large lamellar patch graft here for effective rehabilitation. Again, blepharokeratoconjunctivitis cases with immune melts with iris tissue incarcerations also need to be effectively managed with simple full thickness patch grafts here. Again, these are a couple of other extensive other indications here. This is another case of blepharokeratoconjunctivitis with an extensive superior melt here. And you have a custom patch here, a crescentic patch, full thickness for reconstruction of the ocular surface. This is yet another case of a cystoid cicatrix following a case of SICS, which was referred to us here. And we had to do a custom scleral patch here to effectively reconstruct the ocular surface here. So here we have a variety of indications using not only donor corneal tissue, but corneal scleral tissue as well for effectively reconstructing the ocular surfaces of the eye. This is another case of ocular surface dryness here, a dry eye because of rheumatoid corneal melts with punched out epithelial defects perforating, and you would need a small lamellar patch grafts for reconstruction of the ocular surface in these scenarios here. Again, large melts following pterygium excisions such as this here. And the good point here is we could effectively use corneal tissue itself here rather than scleral tissue for effectively reconstructing these surfaces. But do remember to cover these surfaces with a conjunctival graft or amniotic graft postoperatively. And this helps in effective rehabilitation of these surfaces. The graft subsequently opacifies here, and you have better tectonic strength and better tissue handling when you use these tissues for surface reconstruction of such extensive melts. Another exciting case is a case of an intracorneal cyst here following a suture removal epithelial cyst here, which was recurrent and was not responding to the various other modalities here. And again, it's a lamellar, a flap lift and a cyst excision, and replacing the central part of the stroma with a donor stromal tissue from a non-optical grade cornea here. And this patient again is visually rehabilitated to about 618, improving to 6.9 after the simple maneuver using non-optical grade tissue here. I think we will move on to other indications such as donor corneal limbal tissue harvest for use of CLET cases where we would use bioengineered tissues after we cultivate our limbal epithelial stem cells here. And from there, we moved on to SLET here where we reconstruct the ocular surface and simple limbal epithelial transplantation. So these are other multiple uses of tissue from a single corneal tissue here. Again, another extended use of donor corneal tissue is where we use it to mount our keratoprosthesis devices here. And again, this is putting non-optical grade corneas to good use for visual rehabilitation of some of these dire surgeries here. So we now see that donor corneal tissue has extended indications from penetrating lamellar procedures for research and training, a variety of patch grafts here, limbal stem cell harvest, and of course we also do use the donor tissue or corneal tissue to cover our scleral tubes and tube implants when we are taking them off for glaucoma drainage devices. I think I will stop here and thank you for the opportunity to be part of this wonderful symposium, and acknowledgements to the National Eye Bank for all the support it gives us corneal surgeons at RP Center. Thank you very much.
Thank you, ma'am. Thank you so much. So any question from any of the panelists? Dr. Rishi is here. Dr. Rishi.
Fantastic presentation, Vanati. You've covered the entire range of where all we can use donor tissues effectively. I think she's covered it very comprehensively, right from patch grafts, full thickness, and all the custom component related surgeries. I think PDEC is one thing she just mentioned in passing, but didn't actually elaborate on it. So that would be another area where the surgeons who are now getting into posterior keratoplasty are looking at the benefit of a little bit of scaffold, which the DMEC doesn't provide, which we can get with the PDEC.
Yes.
So I think exciting times also for corneal surgeons, and that's it.
I think one more indication which I did miss out is now Bowman and stromal implantations for tectonic integration in keratoconus cases here. It still perhaps is in the stage of as an alternative to collagen cross-linking, but I think we would be seeing more exciting evolutions of how we can adapt it to a management of ectasias.
Thank you, ma'am. Thank you so much. Any comments from Professor Namrata Sharma? Ma'am is working on the artificial corneas now, so maybe that is a newer dimension to cornea surgeon. Ma'am, any comments?
I think everything was very well covered and all the points were covered in this. Of course, PDEC is one area where not very many people are working, but I think it has a good. The advantage of doing PDEC over DMEC is that you expand your area of the donor pool, because you can even take younger donor corneas, which are difficult to handle for DMEC tissues. And also in the randomized control study where we compared PDEC versus DMEC, we found that the rebubbling rates for PDEC were much less as compared to DMEC, because that's a splintered DMEC graft.
Okay, Bhupesh, I thought in a little different way. I thought if you don't get a good optical tissue, how do we, sustain the keratoplasty in scenario like this? And one you pointed out artificial, corneas, which people are working on, costly device, but the future may be there for these. Like certain times in a COVID time, we had used, glycerin preserved eyes. We have used, tissues which were not suitable sometimes also, and subsequently they were replaced with the optical tissue also. Especially, therapeutic surgery sometimes can be an emergency, and you may not have the access to a good optical tissue. There you can use a glycerin preserved tissue and subsequently replace within a week or so, whether you have taken away the infective load also and saved the eye globe, and subsequently you can do optical graft also. Like you have used tenons for a various as a patch graft. I thought that other part of a scenario would be covered, but Balaji did a wonderful job.
Definitely, sir. Cornea availability is a major issue. Sometimes you don't get a single cornea. Sometimes you get a multiple calls to take the cornea.
Yes, sir. I think in some centers they also preserve the host tissue taken from optical keratoplasties and use them for therapeutic keratoplasties in dire scenarios where they do not have donor tissue availability.
No, I think, sir, it's just inequitable distribution. Some centers have excess amount of corneas and we keep getting requests to use them, and some centers have paucity of good quality donor material. So it's inequitably distributed. That is something which we have to look at.
Another thing that can be added, I think, to the list would be the use of a lenticule, which is not really a donor tissue. It didn't come in as a donor, but lenticules are coming out of SMILE procedures. And the use of lenticules for cross-linking, for tectonic support are now, of course, becoming used. So I think that would add to the list of where issues can be utilized.
Correct.
Thank you, sir. Thank you so much. So, Dr. Prafulla, I think we can move to the next session of this webinar.
Thank you, Bhupesh. So now
I think, Prafulla,
yes,
because it was a surgery only, we can go to surgery now.
Sir, you can have your talk. Then we'll start our corneal ectasia session.
If the other speaker agree, ectasia people agree to do it towards the end. Dr. Ritu? Okay. Namrata, you can start.
All yours.
Okay. Let's go to the surgical area.
Chief RP Center. It's okay.
No. We're the first speaker in surgery wise, Praful.
Sir, you are always first.
Sir, I think you
Chief
can.
RP Center.
Sir is always first. Sir has to go to attend 2 weddings.
The talks in
only one commitment, so sir gets priority.
Okay, thank you.
Yeah. These are not related to each other, so you can start. You can have your PPT first.
May I introduce Professor Titial? I think he don't need any introduction, but as a formality, I'm introducing sir. Sir is a head of RPC AIMS, and sir is going to speak on MIOCT guided endothelial keratoplasty. And sir has more than 400 publications, more than 6,600 citations, 6 books, 60 chapters, all the award, Distinguished Service Award, Senior Achievement Award, AO, APA Service Award, and almost everything he has. So let's listen to Professor Titial now.
Thank you, Bhupesh, for our kind words. Indeed, I would like to really put this word congratulations to the DOS team, the new executive, especially the president, Dr. Rajendra Prasad, and secretary, and Bhupesh and Praful, putting this, cornea webinar into the public platform. As we had a very nice presentation on keratitis and the surgical aspects of corneal tissue, I think Dr. Vanati did mention that we have shifted to a customized corneal procedures that includes the replacement of disease part of a cornea and replace the same part of a donor healthy tissue in that. In that way, endothelial keratoplasty has really changed the entire aspect of managing the large number of cases which are actually would require only endothelial transplant to be done, which we succeeded for now more than a decade in terms of doing a very nice customized surgery for our patients. No financial disclosure for this talk from my side. What is the role of IOCT? That is a OCT which is incorporated into the microscope. So basically, it's going to really give you the chance to see what is not visible on the table under a microscope. Sometimes it doesn't give you a 3D picture, which you could see like this. If you look into this particular case here, we thought that surgery was complete, but if you see the OCT, still we had the gap. So it tells you that you have to do some more manipulation in these patients. DMEC, what Bharati talked about, we still have to learn how DMEC is going to be a perfect surgery for all corneal surgeons. So if you have a visibility like IOCT, definitely it will improve the outcome for a DMEC also, where your chances of failure will be less and the subsequent rebubbling chances will also go to a very minimum so that you preserve the more endothelial cells for your patients. So basically, it is an in vivo optical biopsy where you can see the cross section both horizontally and vertically also to help you in a diagnosis on table, surgical planning, decision making, also monitoring the case what is going through in each step of surgery of cornea also. So it is helpful for retinal surgeries, cataract surgery, but cornea surgery, it has really evolved in a manner where you can do everything, like a donor preparation for DSEC, on table, a preoperative post anatomical assessment. Exactly, you can see from the epithelium to the right to the posterior capsule of eye, the IOLs also. And intraoperatively, you can visualize each surgical step and actually see what is happening throughout the surgery. The dynamics of each procedure can be seen also. Then let me just take you through the donor preparation for our lamellar keratoplasty, mainly for our DSEC tissue, where you can see automated DSEC requires the good assessment of a tissue because IOCT will accurately measure the thickness of a donor cornea and it tell you which type of keratome or a head you have to use for these patients. Sometimes you may ask for a double or a pass technique where actual corneal thickness measurement is very important because we know that ultrasonic measurement after you cut the tissue is very difficult to get a good reading, where IOCT is very, very helpful in those cases. Like for a pre-cut tissue, you can see this is the corneal thickness here, which could be seen here. Accordingly, we are showing the microkeratome, and this is after the cut. You can see how uniform that tissue had cut, and all these things can be assessed. So this gives you a chance what you can see what is happening to your patient, especially when you're scoring the Descemet. You can see here the Descemet is still attached in one area. This can be taken care of. This is the area totally clean, and this still has a Descemet, especially in hazy corneas where you can't see clearly. Apart from the staining the Descemets or using the metallic reflex, if you have IOCT, it can really give you a lot of advantage happening in these cases. If you see this particular case here, which we described, the double ring sign by which tells you that you have a very nice orientation of graft. Apart from that, if you have IOCT, you can see this bevel sign, which tells you that endothelium is rightly placed, and this is the correct orientation of a case. And you can go ahead with a proper attachment in these cases. Then IOCT also helped us in knowing that how much will be time required for a intracameral pressure to be maintained. And this is a surgery which I'm showing you. The thickness can be measured very, very effectively with IOCT. And accordingly, we can choose the microkeratome. So this was around 540 thickness. So we have chosen the keratome of a right size, and we are running. This is the Gibor microkeratome, which gives you a various thickness of heads. You can do a very nice management to achieve the ultra thin DSEC lenticule. Surgery is nowadays the DSEC has shifted to 100 or 100 micron less thickness of donor tissue. You can see this is the donor lenticule underneath, and this is the superficial part of a lamellae. This can be used for a lamellar procedures also, anterior lamellar corneal procedures. So no tissue will be wasted. In fact, we can use all parts of tissue after a perfectly done microkeratome assessment, then cutting the tissue in a size. Normal size of donor lenticule should be around 3 millimeter less than the wide to wide diameter host. And that will give you the nice, you can say, coverage of an entire diseased tissue, which you would have removed. So this is, we are shifting to the Busson glide. So this will be a pull-in technique, which I'll be using for host cornea. This is the Busson glide. Now I will shift this graft to underneath this particular nozzle of Busson's glide. So this protects the tissue, and with the long, this is ILM peeling forceps, which goes from other side to other side. This is the nasal technique I had described. The graft is pulled in, subsequently inject the air, and you can see the end of a surgery where graft is very nicely attached. You can see here. So this tells you that your surgery is going to be much more fruitful, and chances of rebubbling will be less. Let's see what advantage we for IOCT in DMEC surgery also. So this is the correct orientation of DMEC, correct orientation of a tissue inside the DMEC case, which is Boston sign, and this is the reverse one. These are various signs which you can see in cases to actually know if your graft is well oriented. So this is a correct orientation of graft inside the anterior chamber after inject. So this is a representative video. I'm injecting the DMEC roll inside the eye through a 2.5 incision. The roll is inside. Now you can see that DMEC is completely rolled. Difficult to see which side correct or incorrect. So once you make a little tap onto the corneal surface, graft will slowly open up. And then you can realize what is the actual orientation also. Now this is the partially open graft, and with little bit of opening, you can see this is the right orientation of a graft inside. The IOCT gives you a real help for assessing the orientation of graft in a correct manner. So this is how the graft is oriented inside the anterior chamber. Now next step is to open the entire graft flat onto the iris surface. So every procedure in a DMEC has to be done over the iris surface and open in a very gentle manner. So I'll be pressing from one side after shifting the graft to centralization. Then subsequently, with one pressure and tap, graft will open. So this is the totally ab externo technique to open the graft. And once the roll is completely open, you can see it is now almost open over the iris now. Next step is to inject the air bubble inside to push this DMEC roll towards the endothelium. This will do, you can see the concave side is up now, which is the correct position. Once you inject the air bubble, the graft will get attached to the bare stromal surface. We have removed the disease defects from the patient. Here in a DMEC, we don't have a stromal tissue. Therefore, the outcome is going to be better in terms of early recovery, and the quality of vision is also better than a DSEC cases. In the long run, the endothelium survival is also better. Though in a beginning learning curve, you may have to do a multiple rebubbling sometimes. Graft unfolding may be difficult. You might lose more cells. But yes, once it's done effectively, correctly, it lasts for a longer time. After around 3 minutes, we take out a little air bubble, and this is the correct orientation, attachment of a DMEC graft. So surgery, when goes correctly, simple. And nowadays, we do a sutural surgery in all these cases. What happens if you have incorrect orientation? This is a reverse orientation of a roll, which is against the normal edge. This is the roll inside the eye. So you can see this is the reverse orientation. In such cases, the advantage of DMEC is you can refloat the entire DMEC roll and get to correct orientation, which is difficult in a DSEC case, which is thicker. You can't unroll inside. Very difficult to unroll there. So DMEC has this advantage of we can do a refloating of a graft. Now I'll inject the fluid to refloat this graft. So that can be done by a side port. And with one jerk of fluid, the graft goes to one side, flips to a normal orientation here. So this is just done with the fluid only. You don't have to do a physical play with the DMAC reticule, which may be possible as you're talking about PDEC. It may be possible to do a little bit of a manual manipulation in the PDEC case. Now I've achieved the correct orientation of graft, inject the air bubble, and it will get correctly positioned as you see here. So this is air injection, correctly positioned. This luckily also had a S mark, which is correctly oriented in these cases. So this is what IOCT adds into. This is publication which is published by Dr. Namrata Sharma. Especially in those cases where you have a hazy cornea here like this, where scoring is also difficult. The graft orientation is also difficult to appreciate through the microscope. But if you have this IOCT, really gives you a nice appreciation, which I showed in the video, correct, incorrect, and you can redo it, and your results improve drastically if you have IOCT attached. To summarize, intraop OCT really is helpful all cornea procedures, not only for EK, for every procedure like DALK, anti-lamellar keratoplasty, in a DSEC donor preparation, and DM scoring in both DSEC and DMEC, and looking for orientation of DSEC lenticule or the DMEC role is really helpful to improve your outcome for all type of cases, especially when it really gives you advantage of a case where you can see everything correctly. Thank you for listening and giving this opportunity.
Thank you, sir. Thank you so much. It was a wonderful talk, and these machines always makes your work very easy. So just my personal question to you, sir. So do you feel, what percentage you feel the role of this machine for a DMEC surgeon?
Today, I think if you ask all of us, it has 100% role in doing all corneal procedures. We can't think of doing corneal procedure without the IOCT now. I can say this because we have access to these microscopes. It's not that if you don't have this microscope, you can't do surgery. People are doing a wonderful surgery without this attachment also. But if you have this, then you get dependent to these equipment, because you can see better and it makes your life easier also on the table. Both for doing a normal procedure also, when you have a complication also, you can see better and you can manage better also.
So do you recommend that who can afford these machines, they should go for these tools?
Yes. I've been telling this in every presentation, especially a high volume corneal practice institutions should have this microscope. And pretty sure within a few years, we'll have some Indian company coming with these attachments also. I think Appasamy is working on this. And we very soon will have, there's a lot of competition coming up in the market also in attachment of OCTs. And I think the actual rate will also come down with the multiple companies coming up.
I think that will be great for all of us. And thank you, sir. Thank you for your enlightening talk. Any comment from any one of the moderators or any of the panelists?
Dr. Bhupesh, if I can make a comment.
Yeah, please.
After that fantastic talk, and sir has been a teacher, and until we do not have IOCT available for the DMEC surgeons or cornea surgeons, I think something which we use very regularly for DMEC surgeries and for difficult DSECs in blind procedures is a light pipe, which goes a long way along with the microscope. And you can actually see the orientation if you have stained your tissue enough for DMEC. So that was just one point I wanted to say here.
Yeah, absolutely true. Because we have to work on various other ways to see underneath what is happening in the sometimes hazy cornea, and especially in cases where you have a little difficulty where your stain goes off, then it's a very, very difficult time.
Thank you, sir. Thank you so much for your talk, and I think you can leave for your for the marriage now. Thank you, sir. So, Praful, I think we can go back to our original plan. Dr. Praful.
Okay, so our next session will be on corneal ectasias. Our first speaker is Professor Ritu Arora, ma'am. Ma'am is a director professor at GINEC, and she has almost 150 PubMed index paper and almost 15 national as well as international trial with her. And recently she has published a lot about CXL and DAL. So that's why I requested, ma'am, you please take this talk, because nowadays everybody is doing CXL, but it's very important to know what to do, how to do, and what to remember while doing CXL. So welcome, ma'am. Please, you can start your talk. Your slides are visible, ma'am, but I think you have to unmute yourself.
Ma'am, you're muted. Ma'am, you're muted.
Yeah. So thank you very much. You can hear me now?
Yes,
yeah.
ma'am.
Yeah. So for this opportunity, and I have prepared my lecture to a very, very basic level because nowadays everybody is doing cross-linking, and patients are going for their routine refractive screening picked up as maybe keratoconus or not keratoconus. So, and they're taken up for CXL. So there are certain points which we really need to be aware of and different aspects which I will be talking about. Yeah. So as always, whenever we do any procedure, we should know what is the procedure, where to use it, when to use it, and why to use it. So whether I'm justified in using whatever procedure which we are going to be doing. And starting with very basics, that cross-linking is nothing which is very, very old. It's everybody knows about this procedure. First patient was done in 1998, and it was initially started in 1930s. And when the first procedure was done in 1998, the major indication which was given was that it reduces the progression of keratoconus, and normally also the cornea stiffens. So first thing I just want to talk about is the patient selection. Maybe there are people who are not doing cornea in this forum, they're also listening. We have to really know and understand to read our topographies well. It's not uncommon when patients who just have high astigmatisms, maybe 3 or 4, and they do not really have keratoconus, and they are diagnosed as keratoconus and sent for cross-linking. So this was one of the patient, representative photograph, topograph, which I've just tried to show, where a patient was referred for cross-linking. This is another representative picture which I had. Was patient was having a post-RK irregular cornea, and there was incisional ectasia, and the cross-linking was advised. So the first question is the right patient selection, so that one should not take that it's an extraocular procedure and advise it for everyone. The major indications for cross-linking is that it halts the progression of keratoconus, so ectatic corneas. The extension of this is the use in iatrogenic keratoectasia, that is in post-LASIK procedures. Of course, now it is also being used in infectious keratitis management. Earlier, there was a wave in sometime in 2010 onwards that to be used in bullous keratopathy, that it delays the need for PK, but I think no longer one is going for this indication. It was used in scleral treatment in rabbits in progressive myopia and in corneal melting disorders. And now it is also used with other treatments like intracorneal rings and topo-guided photoablations. The basic requirements for cross-linking, that we need a photoinducer or a riboflavin dye, which could be isoosmolar or hypoosmolar, which is used when we have thin corneas, which riboflavin may be with dextran or without dextran with hypermellose combination. And generally, preferred mode is to use after epithelium removal, because intact epithelium does not let the dextran to go in. The transepithelial mode is also there, and I'll be talking about it a little later. Then we need a UV light, and then which was the absorption peak of the riboflavin is at 370 nanometers, and the first device used a wavelength of 365. nanometers. The photochemical reaction, which occurs between UV light and riboflavin juice, it induces free radicals and thus leading to the creation of a chemical bond between collagen fibers. The different types and the protocols for cross-linking, which we know of, conventional is the Dresden protocol, which has been there from 2001 onwards and has shown excellent results. Since the overall time it takes in this procedure is long, the other protocols have come, and then more commonly, which we are using now, is accelerated, where 9 and 18 milliwatts is used. Transepithelial, I've already talked about, where preferably used for thin corneas. And within the accelerated, now we have the pulsed mode of the cross-linking also available. For thin corneas, we use the assistance of contact lens or a smile lenticule. And in thin corneas, we also use hypo or smaller riboflavin to thicken the cornea and then go on with conventional CXL. After having known the different protocols, which I'm sure you all know, but to say that the cross-linking is absolutely complication-free is not correct. Therefore, our patient selection has to be absolutely right. And not to scare you, but these are all the complications of CXL which can occur. And off and on, I mean, we've all landed up with these complications. So we really have to have a right patient selection, right procedure, so as to not to get into this kind of a issue. Because CXL is primarily used to halt the progression of keratoconus. So nowadays, people are even using it with 6/6 vision, which is not wrong, provided the patient is correct. The complications we may have is corneal haze. Transient haze is always there in most of the patients, which usually goes away by 3 to 4 weeks. But some patients may have persistent corneal haze. There may be diffuse lamellar keratitis. Suppose there may be some, rarely in reactivation of viral keratitis takes place. Infective keratitis, I mean, even RPC group has published a series of infective keratitis post CXL. There may be corneal scarring if suppose it's a wrong patient selection. If suppose the corneal thickness was not correct when CXL was used, we prefer to have a corneal thickness which should be 450 microns to begin with, so that after epithelial removal, it should be at least 400 microns. Persistent corneal edema has been reported. There may be deep vascularization, iris atrophy. Rarely we've had corneal melts. I mean, in my past 12 years of CXL practice, I've had one corneal melt and patient had to be taken up for PK, which could be due to acute inflammatory response and hypersensitivity to riboflavin. Or inadvertently, in our case, it was not used, but sometimes we've seen in other cases use of diclofenac post-CXL. We may get ring-shaped corneal opacities, of course, and the commoner one, which though it has come down over here, is sterile infiltrates, which I'm sure most of us must have seen. And these infiltrates, when they come up, they usually come up at 48 to 72 hours after the procedure, and which may give a doubt whether we are dealing with infective or non-infective infiltrate. Very common in patients because these patients may have coexisting VKC, since keratoconus and VKC by and large go hand in hand, and the ocular milieu is not correct. And so sterile infiltrates are not uncommon, sterile melts. At times we have seen recurrence of keratoconus and even shield ulcer post CXL. This is one of the posters which we presented in Academy showing the complications of cross-linking in keratoconus in young patients. And most of these complications, when we retrospectively analyzed, they happened in cases that they had associated VKC and the upper lid, upper palpable conjunctiva had multiple papillae. So nowadays, even our residents have become very cautious. Whenever a patient comes for CXL, it's mandatory for them to evert the upper lid, see the status, that how bad the papillae are, And sometimes we've already had patients where a 10-year-old, 12-year-old child of VKC, severe VKC with cobblestone papillae and conus, which is 50, 54 diopter. And in children, as we know, conus progresses very fast and they have to be taken up for CXL. We had to resort to giving them even systemic steroids. So a play of topical steroids and the systemic steroids or immunomodulators before being taken up for CXL is mandatory if it is planned with associated allergic condition or VKC. Therefore, I have just put it in one slide. The issues which may arise may be due to improper patient selection, or it may be due to associated VKC, which may be active or quiescent. Corneal thickness. So preoperatively, as I said, corneal thickness preoperatively ideally should be around 450 microns. And before we start the UV ray, and the patient is exposed to UV rays, at least it should be 390 micron plus. So now it has become mandatory in our setup that we do intra-op pachymetry and then only continue with the cross-linking. At times, the thickness is a problem because of when we do it on pentacam and we do it on op scan and on, sometimes we do not get readings which are matching, or they may be, say, 370, 380 micron, you do not know. So the protocol which we use ASOCT guided measurement of the corneal thickness and decide whether any scarring is there preoperatively, because a lot of these patients may be contact lens users. Epithelium removal may not be very easy because of some scarring, and so we have to use alcohol to remove the epithelium, and sometimes when you really abrade the cornea too much, it can get infected. Then issues may be related to UV exposure. As I've already discussed, different protocols, whether we are doing conventional, we are doing accelerated, we are doing pulsed. So we have to be very sure, for what duration we are giving UV exposure, whether we are using riboflavin with HPMC, dextran, and issue can also arise when the TBCL is put at the end of the surgery. This is just another diagrammatic thing as to why the complications of CXL may happen. If suppose keratocyte apoptosis is there may be delayed reepithelialization. Normally, because we remove the corneal epithelium and reepithelialization takes place in 48 to 72 hours, that's when the BCL is removed, but it may be delayed when if dry eye is there. If it's nerve fiber damage, we get sterile or maybe infectious keratitis. Endothelial toxicity, because if you've taken a thin cornea, you may get a corneal haze. If treatment failure, you may get corneal scarring. So these are some of the pictures of our complications of CXL, and that's, nothing to scare you, but this last picture which I've shown is that which even I was very scared. This is about 8 year back picture. This patient had atopic conjunctivitis, and I was very new in cross-linking. And atopic conjunctivitis, 30-year person was taken up for CXL. He landed up with this kind of a picture, and of course it was it looks infective, but it was actually not infective. Multiple scrapings were sterile, and he underwent a therapeutic graft after some time. And these are those pictures, and these are some of the pictures which is showing shield ulcer which came up after CXL, and of course it resolved. And these are another picture where there was sterile infiltrate and ended up with corneal scar. And this is what we published, sterile infiltrate, which in a conus with moderate VKC, which came up like this after 48 hours. And of course, it healed because one had to be very judicious in use of topical steroids. The other protocols that I discussed is a high fluence CXL after Dresden protocol, 3 milliwatts for 30 minutes. But the ultra-fast devices are using maybe 43 milliwatts for 2 minutes. That's something which is now come up with LASIK Extra, 9 milliwatts for 10 minutes or 18 milliwatts per centimeter square for 5 minutes. So we have to be very sure where we are setting it up. As far as this comparison of accelerated with versus conventional, it has at least sufficed the non-inferiority trial. and they've shown that it is equivalent to the conventional CXL. So therefore, that's by and large become a routine practice. But I still feel that it does, since the biomechanical effect of the CXL is not as good as conventional. So in young children, 10-year-old, 12-year-old children, I still prefer Dresden protocol and do not prefer an accelerated protocol over there. And then this was just a randomized trial, which I've just, Cornea 2019, which showed that accelerated cross-linking had a comparable efficacy and safety at 1 year follow-up. Then cross-linking in thin cornea, we may use transepithelial, hypo or smaller, or at times we have used iso or smaller riboflavin with HPMC instead of dextran, and we've been very surprised that the corneal thickness picks up. And then, or we may use customized epithelial debridement, decrease the UVA irradiance, or maybe used reduce combination of above, maybe use smile lenticule study, which was published from CFS, and individualized CXL treatment is needed for these thin corneas. Then keratoconus in children in this part of the subcontinent, it is more prevalent, earlier onset, and greater disease progression. So there is always a debate whether we should wait for cross-linking to the keratometry to progress, or to do the cross-linking right at the time of presentation. So we did a study where we did the cross-linking in pediatric patients, and we were one of the fewer studies when not much was available. Now, of course, a lot of data is available, and it said that the collagen, we found that it was safe and effective in children, and at least at that time we had 1 year study, but now we have a follow-up of these children who have followed up for last 8 to 10 years, and we have found that keratoconus has not progressed. So we can safely say that it should be done for children and is very effective in controlling and gives us satisfactory visual and topographic outcomes.
Hello.
Yeah, and then we also presented in Cornea as to when to do it. And now, of course, I still feel in children, one should not wait for documenting the progress, and it should be done right away. But if there is a patient who comes in the late 20s, I hold on. I do not take up the patient for cross-linking. But if somebody is 23, 24-year-old, and we can still take a trial. But if there is a girl coming, and a female patient with keratoconus, I take them up for this for cross-linking, because invariably we have seen during pregnancy the keratoconus progresses and the vision may go down. So both conventional and accelerated are effective in children. So as far as, and now there's a Sienna study also with 5-year follow-up saying that it is effective. Standard epithelium of cross-linking is much better than accelerated versus transepithelial cross-linking. Other indications for cross-linking are for the infective keratitis, which I'm not going to deal with it more over here. But it has also been found to be more effective than the conventional antimicrobial in the correct pathogen. Higher fluence CXL is now being used with Athens protocol for vision. Topo PRK plus 10 milliwatt per centimeter square for 10 minutes may be used. And LASIK extra is 45 milliwatts for 1 minute. And for infective keratitis, 0.25% riboflavin with 5 milliwatt per centimeter square for 20 minutes. And for so
can you just summarize?
Yes,
Yeah,
I'm finished. I'm finished.
So I know it's very interesting and very nice topic.
I'm finished. So in the end, I just want to say it's a promising procedure, and you can combine it with refractive procedure, but it is not entirely complication-free. Performance in topographic keratoconus is questionable. It should be done before visual disturbance take place. So therefore, I say one should not wait for any evidence of progression. Patient counseling is a must, because a lot of patients think that after cross-linking, their vision is going to improve. Cross-linking in conus with coexisting VKC, one has to be extremely careful. In children and in thinner corneas, different protocols need to be used, and we need to avoid limbal area for minimal effect on the regenerative capacity of the epithelium. Thank you very much for a patient listening.
Thank you, Mom, for that wonderful talk. In fact, you covered all the things that we expected in this talk: when to do, what to do, and how to do. And since we are running a little bit short of time, so we'll take questions of corneal ectasia after all the three talks are over. Next talk is about when CXL doesn't work, cornea progresses, but your patient doesn't want to undergo surgery. So that aspect will be covered by Professor Rajesh Sinha. And I request Bhupesh to introduce her and invite to the talk.
Thank you, Praful. So the next talk will be by Dr. Rajesh Sinha from RPC AIMS, and Sir is in the Department of Cornea. And Dr. Rajesh is personally one of my favorite ophthalmologists in Delhi, and he's a very nice person. And Sir will be speaking on ICRS, that is intracorneal ring segment in keratoconus, where they stand. Let's listen to Sir now.
Thank you, DOS. Thank you, Dr. Prasad. Thank you, Dr. Bhalla, Dr. Bhupesh, Praful. I'll be sharing my slides. I'll be talking about intracorneal ring segments in keratoconus. And it was proposed long back. Yeah, it was proposed long back in 1978. And then it was worked on, and then it was approved by FDA for low myopia. But then these days we hardly do it for low myopia, and because there are other options which are better options for myopia. So we do Intacs mainly for keratoconus or post-classic ectasia. These ring segments, I will be talking mainly about Intacs because I have experience about Intacs, and there are some other rings as well. So these intact segments are basically PMS segments, 150-degree arcs, and they are placed intrastromally into the cornea at 7mm optical zone, 8mm optical zone. And the basic idea is to insert the intracorneal ring segment in the peripheral cornea inside the stroma, so that it creates a arc shortening effect and causes central flattening. And it is placed at 2/3 of depth of cornea. And because of this arc shortening effect, there is central part that gets flattened, and the peripheral part beyond the ring segment may get steepened. But the basic idea is to flatten the central part, and that was the basic idea when we started doing it for myopia, to flatten the central cornea. But that works in keratoconus as well, because in keratoconus we do have keratometric myopia. So keratometric steepening, and that results in myopia. So Intacs has basically two major groups. One is the standard Intacs, and the other one is SK. SK is placed at 6mm zone, and the standard is placed at 7mm zone. SK has a oval cut section. Standard has a hexagonal cut section. And this is a nomogram which is there. Depending upon the refractive error, this nomogram was made. Depending upon the cylinder, you can modify. And the idea is that you have a symmetric segment and asymmetric segment. The symmetric segment is placed when you have to correct more of a spherical component, or if the cone is more central. But if the cone is not central, that is in posterior float, if less than 50% is in the central part, then that is asymmetric cone. So in such cases, you put asymmetric segments. As I said, it was approved by FDA in 1999 for myopia, for low myopia, but we hardly do it for low myopia these days. And it is mainly used for keratoconus. And it not only corrects a little bit of myopia, but it also corrects astigmatism. And the basic idea is to reduce the irregularity of the cornea. So how do we plan the implantation or insertion of these ring segments? The first and foremost thing is that we have to look for the manifest refraction and the topography. The map, that is most important thing. That gives you an idea what type of segment you are selecting, where will you place the incision. All these things is heavily dependent on the map. And so you have to identify the incision axis. And if you have, say, refractive error of, say, -4 diopter sphere, -4 diopter cylinder at 50 degrees, then in such a case, you convert it into plus cylinder form. So the plus cylinder form is showing axis at 130 degrees. So the incision will be placed at. Let me. So this is what we do. As you can see here, the incision is being planned at 130 degrees. Then you identify the cone. As I said earlier, that if more than 50% of the displacement on the posterior float is within the central zone, central 3 millimeter zone, the cone is classified as a central zone. And if it's beyond, if it's more than 50% is outside the central 3 millimeter zone, it is a eccentric cone or a decentered cone. And then in a central cone, you place a symmetric segment. But in a decentered cone, you place either asymmetric segment or a single segment. Again, as I said, another scenario wherein the plus cylinder form is showing axis at 130 degrees. So the incision placement will be at 130 degrees. And this is the central cone. As you can see here, that in the posterior float, this part more than 50% is within the central 3 millimeter zone. And that is why you will place a symmetric segment. Now, another scenario wherein, as you can see here, the float is showing that it is mostly outside. You can see here the appearance of the posterior float. It is showing that it is mostly eccentric. So in such a case, you can place either asymmetric segment or a single segment. Again, when you see that the posterior float is showing that it is mostly outside the central 3 millimeter, then again you will place either asymmetric cone or asymmetric segment or a single segment. My personal choice these days, in order to correct astigmatism, like something like this, a sphere of minus 0.5, cylinder of minus 4 diopter, and this kind of an eccentric cone, I will go for a single segment. Single segment so that it corrects the cylinder. My idea is to correct the cylinder in this, not to correct the sphere. So that is how we plan. And the axis, as you can see here, minus cylinder form is giving 170 degrees. So we convert it into plus cylinder form. The axis is 10 degrees. So the incision will be placed at 10 degrees. It's a decentered cone, and that is what we do. There are some contraindications, like if there is collagen vascular disorder, or if at the site where you are inserting the mid-peripheral site at 7 millimeters, if the thickness is less than 450 microns, we should avoid it. And as far as segment selection is concerned, I have already told that if it's a central ectatic condition, then we will use a symmetric segment. If it's a decentered ectatic condition in the posterior float, we will select either asymmetric segment or a single segment. These days, when I see that if it's millicylinder, as I showed you an example, then I will select a single segment. And these are the femtosecond settings. You can do manually as well by mechanical separator. You can use femtosecond as well. The internal diameter is 6.8 millimeter for standard, and for SK it is 6. And this is the outer diameter 8.1 and 7.3. This is what we feed in the femtosecond laser platform, and this is how we do it. In the case of keratoconus, or post-classic ectasia, we perform intracorneal ring segment, and we do cross-linking as well. So the idea is to modify the curvature, modify the surface of the cornea, modify the refractive status, and then stiffen it by cross-linking. This is how we do with the help of femtosecond laser. So we open the radial incision, and then the initial part of the track has to be opened with a mechanical separator. And this is what we do in both the sides. And then we put the ring segment on one side, and then we place the ring segment on the other side, and then we put one suture. And then after that, we debride the epithelium within this area of, inside the area of the ring segment. And then we put riboflavin, and then we do cross-linking. So this is the basic idea, is to change the curvature, change the topography, and then you can stiffen it with cross-linking. This is just, I want to show you how the mechanical dissection is done. So you mark the center, you make a radial incision with the diamond blade, And then with the mechanical separator, you separate. It is at 70% of the thickness of the stroma, and then you place the ring segment. So in conclusion, intracorneal ring segment these days has indication. It has limited indication. It has very good result in post-classic ectasia. It has good result in primary keratoconus as well, wherein you want to correct the astigmatism, because in keratoconus you have high myopia. You can't correct it with ring segments. So the myopic part, the spherical component, cannot be corrected, but you can reduce the astigmatism, and you can combine it with some phakic implant as well. So put a ring segment, do cross-linking, stiffen the cornea, reduce the astigmatism by ring segment, and then later on, for the residual astigmatism and the spherical component, you can put a phakic implant as well, and it works well and provides good visual outcome in patients who are not very good candidates for contact lens. Otherwise, contact lens definitely is the best option, which will mask the irregularity that is seen in keratoconus cornea. So it provides good refractive and topographic stabilization, and we can do it both with femtosecond laser as well as by mechanical separator. So thank you very much for your patient listening. Any comment or suggestion from the panel?
Bhupesh, you have to unmute yourself.
Thank you, sir, for your wonderful talk and the surgeries. Personally, I've not seen the manual intacts till now. I used to do femto intacts, and it was nice to see. And must be challenging to do manual intacts. And maybe in the end we can discuss after this the last talk by Professor Namrata. Praful?
Yes, we can cover the corneal ectasia then.
Yeah. So coming to the last and the final treatment of keratoconus, that is called talc, and Dr. Namrata or Professor Namrata will be speaking on mastering talc. Ma'am is a head of cornea unit in RPC AIMS, and she has more than 600 publications, so many books, many awards. Currently, she's a secretary of All India Ophthalmic Society. And in summary, we can call her as an ophthalmology icon in India. So let's listen to ma'am now.
So thank you, Bhupesh, for that kind introduction. And I would really like to congratulate Delhi Ophthalmological Society, particularly Dr. Rajendra Prasad sir and Dr. J.S. Balla for this DOS Global series, I think, which is really doing very well. I would be talking to you about mastering deep anterior lamellar keratoplasty, and there are no financial or proprietary interests. And that we know that there are a lot of techniques by which it can be done, and depending on the indication, we change our technique. The gold standard remains the big bubble talc for ectasias, but there are other ways in which talc can be done. And this is just to show how a type 1 big bubble is being created after doing a partial thickness trephination up to 60 to 70% on an intraop OCT microscope, followed by the air which is injected in the supradesmats membrane compartment, and a nick which is given in the overlying stromal layers. And you can see that as the air aggresses out of the supradesmats compartment, the desmats membrane marches towards the overlying stromal layers. Now, this is again reinforced with the help of the viscoelastic, which is injected into the supradesmats membrane compartment. This falls down just like a kangaroo's pouch, and the overlying stromal layers are then dissected with the help of Vanna's scissors. And the desmats membrane is now bare, which is staring at you. And this is a donor cornea from which the desmats membrane has been removed. And then this is then sutured with 10-0 monofilament nylon sutures. Now that was type 1 big bubble. This is type 2 big bubble, which goes from the periphery to the center. Again, it goes into the supradesmats membrane compartment, as can be seen. It has come only up till here. And when we are actually doing a paracentesis in such cases, one has to be careful, because you can perforate the desmats membrane. Air is now being, paracentesis is now being done, and see how the air actually fills up the compartment. And just again, the nick is given in the overlying stromal layers. When it is a type 2 big bubble, then the whole complex of the desmats membrane endothelium moves very fast. When it is a type 1 big bubble, it moves rather slowly, as you saw in the earlier movie, and then This is again followed by the reinforcement with the viscoelastic and subsequently the excision of the layers. Now here, while doing dissection, there is a perforation which is present inferiorly. This part is complete Descemet's membrane, only this last quadrant remains, and this can happen in any DALC surgery for that matter. And when that occurs, then one can leave a little bit of tissue right at the area of the perforation, and this seals the perforation, and then this is followed by the graft, which is then placed onto the recipient bed. Now, DALC is possible in healed hydrops also, and in these cases, especially in cases of keratoconus, we do not do big bubble DALC, although people have described it, but we try and do a deep anterior lamellar keratoplasty, and we do a layer by layer deep anterior lamellar keratoplasty, and just as we come to the area of the healed hydrops, we change our level of dissection, which is a little anterior as compared to the one which where the dissection was going on previously. So that area of the scar is completely bypassed. And as we do this again, notice that there is a scar which is present there, but it is in the paracentral area. So the post-op result is good in these cases because the scar doesn't come into the central part of the cornea. And this is just to show the same, that if you do a DALC and scar doesn't come on the central part of the cornea, then the visual acuity can still be good. Now, this is a layer by layer DALC, which is being done for a case of chemical injury where already slit has been done. So as you do layer by layer, when you come to the area where it is absolutely clear, this is partial thickness grafting which is being done. The graft can then be sutured with the help of 10-0 monofilament nylon sutures. And this is another case where after slit, DALC has been done, and yet another case where slit has been done earlier. In this case, conjunctival grafting is also required. So we do conjunctival autografting as well. But in cases of chemical injuries, DALC is much easier because it rarely perforates because of the fact that the cornea is not very elastic and it is already pathological. And this is again a case of post-DALC after slit, and in case of post-DALC in a case of a firecracker injury. Then in desmetoseals also, DALC is very easy to do because the disease layers are already ready to be stripped because they are hydrated. So all you have to do is inject some viscoelastic at the edges of the desmetosele, and then now this is the Descemet's membrane which can be seen over which the graft is placed. So you are still extraocular, and this is to show the pre and post-op picture of the same. This was a case of large desmetosele in which patient had meningitis, so we couldn't give GA. We couldn't even give a peribulbar anesthesia because this would perforate. So all we did was we glued a piece of tissue, again a deep anterior lamellar keratoplasty with the help of the glue, and just ensured that the tissue fits is well opposed and is not overriding the edges of the desmetosele. And this is the post-op picture. And of course, visual rehabilitation, a small central PK was done later on. Now, this is something which is unconventional. Even in adherent leukomas, you can do DALC, especially if there is paucity of good quality donor tissue, which happens in centers which have waiting list which is long. And in this case also, DALC was done because the adherent leukoma was present in the peripheral part. So a B-grade tissue or a tissue which was not suitable for penetrating keratoplasty was used. And then again, notice that the central part of the area is quite clear even in this case. Now, this is just to show DALC in case of Salzmann nodular degeneration, which has already been published, and in cases of VKC. And in cases of limbal dermoid also, one can do deep anterior lamellar keratoplasty. This was a one-eyed boy who had lost one eye because of penetrating keratoplasty in the fellow eye. So in this case, only a deep anterior lamellar keratoplasty was done. And this is a very old video when we didn't have intraop OCT microscope, but nevertheless, this is just to show that a customized deep anterior lamellar keratoplasty is being done after putting the graft with the help of the sutures, and then subsequently also gluing it. So this is the post-op picture of the patient. The patient has a visual acuity, good visual acuity, is now grown up to be an engineer, from counting finger 2 meters to 20/40 visual acuity. So to conclude, talc is the way to go for endothelial sparing pathologies. Makes sense in country like ours, where you will not be able to get good quality donor tissue for all cases. It's an extraocular procedure, reversible with minimal rejections and with minimal intraocular complications. So thank you very much for your kind attention.
Thank you, ma'am. Thank you so much. So I think we can start the discussion now, Prafulla. Okay, so
I think we can start the discussion. We can have
have Dr. Rajiv and Dr. Rishi Mohan as panelists for this session. Any comment from you, sir?
So I think we've had 3 different talks, and starting with the last one, I think Namrata has done a perfect job in the presentation, and I think she's just shown the different types of dissections that we can do and how big bubble is not always easy to create, and given us a template of how to approach these cases. As far as the previous talks were concerned also, we've got Dr. Sinha's talk on intacs, and that was brilliant, as well as Dr. Ritu, who completed her entire presentation on cross-linking. So starting with cross-linking, I just like to state that it's been, almost 16 years when Rajiv and I started cross-linking, and it's been quite a journey, and we've pretty much seen all the complications that Ritu had shown, and they all do exist. So it's not that simple a procedure. One thing that I would like to highlight is in her case selection, she mentioned about various aspects. But the one thing that I have seen is that all eyes, even in the same patient, don't need to be cross-linked. And there are many patients who have had only unilateral cross-linking. And it's not such a small number. I would think it's probably close to 10%. And if you keep monitoring these patients, you realize that even after many years, the eye that was not cross-linked is doing well. And so just because one eye needs cross-linking doesn't mean that the second eye also needs to be cross-linked. So that's one point that I thought I would highlight. The other thing is the complications. I've had a patient of corneal decompensation. I've had a patient of persistent uveitis. So I think at least the older machines had an issue with the focus. And I think if you were to deliver the energy a little deeper, one would at least have the possibility of radiating the cornea, the endothelium, as well as going deeper into the uvea. And if this patient is complaining of pain halfway through the procedure, and you know he's well anesthetized, one needs to look at the focus, because there may be some energy landing on the iris, and the patient may actually be complaining of the feeling because the energy is bothering him. So these are the things and tips that I've learned after almost almost 1,000 of these, I guess, by now. So that is important. Intacs, again, fantastically said by Rajesh. He's just covered the whole gamut of things, whether symmetric segments or asymmetric segments. It's not at all used for myopia. I don't think anyone uses it for myopia anymore. It's almost always for keratoconus, and there also case selection is extremely important. We've all had our, invariably, at least in my hands, it always underperforms. So whatever you say and think you will be the outcome, usually the outcome is much less than that. So the cylinder doesn't correct as much, and the spherical doesn't flatten as much as we think it would. I'm not sure about the thickness, though, whether going deeper than 80% would, well, I think if it's deeper than 85%, certainly it would impact the efficacy. But if it is less than 50%, I don't think it will work either. So there has to be some ideal place. I think 70% is pretty much what they recommend. And that's where we should stay. So those are my comments on the whole in one go. Thanks.
Dr. Rajiv?
Excellent presentations by all the 3 people. About Dr. Ritu's talk, I'm very closely attached with keratoconus and cross-linking. As Dr. Rishi Mohan said, we started it long back. One thing we need to be aware of it, most of these keratoconus patients, especially the pediatric age group, are associated with VKC. And VKC can be sometimes very, very severe, and then they cause limbal stem cell deficiency. Now, we need to examine the limbus of these patients very well. There are patients that I deny cross-linking because I find their limbal stem cell population to be not so good on a clinical examination. So I know that the reepithelialization would be a problem. And just like Professor Ritu showed on one of her slides, she got a shield ulcer kind of a picture. The probable reason was the repopulation of the epithelium was not actually adequate because of the poor limbal stem cells in these patients. So we need to be extremely cautious with these pediatric patients or in patients with keratoconus even coming in their late 20s to examine the limbal stem cells, because the reepithelialization is extremely important. About another point about there is that the Dresden protocol or the conventional protocol versus accelerated cross-linking. I have my severe reservations about accelerated cross-linking. Whatever studies I might see is fine, but if you go to the basics of cross-linking, it requires adequate oxygen cingulate molecule within the corneal stroma, in the deep corneal stroma. If you don't have free radicals of the oxygen molecule, you will not have a cross-linking bonds forming. So as it is, cornea is avascular, it does not have blood vessels to have oxygen supply over there. It's dependent on the tear film oxygen. So you really cannot have cross-linking, adequate cross-linking between the stromal fibers if you're doing an accelerated protocol. I have questioned people and even certain authorities who were part of the Dresden protocol on this, and they agreed on the fact that they have tried various things like inoculating oxygen within the stroma, having oxygen supplied directly over the conjunctiva and the ocular surface while doing cross-linking. But eventually in the deeper stromal layers, you do not have enough oxygen to have those oxygen-free radicals, which are the basis of forming these cross-linking covalent bonds. Thank you.
Dr. Riti, you would like to address that last comment by Dr. Rajiv?
No, I agree with him. I agree with him, because though there are multiple studies which say about accelerated cross-linking to be, therefore I specifically said that non-inferiority trial. It's not something which is superior or, to conventional. And I still teach in the round the same thing. Suppose I have my child who's undergoing, I will still prefer conventional than accelerated. I mean, that's what my personal thing is.
I think I agree. I think it's important that we, at least in my personal experience of 16 years, I haven't budged from the Dresden protocol. I still do exactly what I did 16 years ago, and I'm still doing the same. Yeah. It's only in the patients who have undergone a PRK and you're also doing cross-linking, there I go for an accelerated, and there too, I never go faster than 10 minutes. So that would mean you would reduce the time by a third and you multiply the energy by 3 times, but not beyond
that. Pulsed, the pulsed option also, I am pretty happy that way, so at least it gives you some time off within that much time. It takes about 14 minutes, 15 minutes to do that. Yeah, Rajesh, you were saying.
Studies have shown that 9 milliwatt per centimeter square for 10 minutes is nearest to conventional, that is Dresden protocol, and there's studies have shown that there is no significant difference between these two. Otherwise, those earlier ones that we started with that euphoria that 3 milliwatt per centimeter square, 30 milliwatt per centimeter square for 3 minutes will be as effective. No, it's not. So 9 milliwatt. That's why everywhere people are preferring 9 milliwatt per centimeter square for 10 minutes. That is something which is close to the Dresden protocol, and of course, it provides ease of doing. That's and cooperation of the patient. That's the advantage. So that's why used.
No, I think in our cohort, which we did and we are going to publish also, repeat cross-linking, especially in pediatric keratoconus, is more in cases where we've done accelerated collagen cross-linking as compared to conventional cross-linking. So that has come out in our study to be statistically significant. So I think, although it's going in for publication, but I'm sure that with a long-term follow-up, we would come out with, things like this, especially 10-year follow-on study or longer study, because the collagen turnover time is only 6 to 8 years.
Thank you, ma'am, and thank you all the experts. I think now we'll be moving on to our last session, which will be mostly corneal surgery. Our first speaker is Dr. Nidhi Gupta. She is a faculty at Dr. Shroff Charity Hospital. Recently, we have seen a lot of publication from her about chemical injury and SLET. And most importantly, that scleral ischemia article is quite impactful. So we thought, let's invite ma'am to have a talk on SLET. So Dr. Nidhi, you can start your talk.
Yes, thank you to DOS for this fantastic global meeting that we are invited to as a speaker. And in next 10 to 12 minutes, I would be talking about simple limbal epithelial transplant. To begin with, I think limbal stem cell transplant, from the time I remember my times with Dr. Namrata ma'am, where we used to do CLET. It was very difficult for a lot of centers world over to actually do any kind of treatment for patients which had limbal stem cell deficiency. And that was primarily because it required a lot of technical expertise and expensive, sophisticated labs to do a limbal stem cell transplant in these patients. It also required, by other methods like claw, a larger donor eye limbal biopsy to do a limbal stem cell transplantation. The success rate with earlier methods was about 70 to 80% chemical burn patients, where the visual acuity would improve variably in these patients depending upon the initial insult. So from that era, actually now 10 years back, came the first paper by the LV Prasad group, wherein Dr. Sangwan had come up with a procedure called simple limbal epithelial transplantation. This procedure later on went through a test of time, wherein it was actually a group of people world over did this procedure, and it was seen that it was absolutely something which we could do again in our clinical practice and was giving similar results. Until it came up with a large data of 125 patients wherein they had published this data. It was that time, even at Schroff in 2013, a year later, we started with SLET, and our results were absolutely reproducible and comparable to the LVPI group. It is since then that this procedure has shown a long-term 1.5 years follow-up of results which are comparable to CLET and CLAW, which was performed earlier. And in some scenarios, even better in terms of the visual acuity improvement in pediatric age group. So I would be talking about this very procedure of simple limbal epithelial transplantation. And the best patients for these group would be patients of limbal stem cell deficiency, which is secondary to a chemical burn. Patients in which the other eye is doing normal and they're uniocular burn, so that you have enough biopsy which is available for the procedure. Eyes which are preferably wet would do better. And wherein the surface inflammation, which is secondary to the disorder of LSCD, is settled and the acute phase has passed, would be better eyes, which would have a good potential of vision, are the eyes which should be selected for this procedure. The contraindications for SLET would be the other causes of limbal stem cell deficiency, like Stevens-Johnson syndrome and OCPs, wherein there's an immunological disorder behind the LSCD. Cases wherein there is dry eye, and patients where there's unorganized anterior chamber would not give you a good vision. So it is very important that before you actually decide to do a SLET, although it's a simple procedure, you're very clear of the vision potential of this eye, and the other eye is doing normal for you to take up the biopsy. Something which is going to help you would be a good preoperative workup in these patients. So doing a good slit lamp examination of the other eye from where you would be taking a biopsy becomes important. Sometimes these patients would not be giving you a history of an injury to the other eye, and you may have on-table dilemmas from where you're going to take the biopsy when you're not able to identify the exact area of the warts. Definitely, as I mentioned earlier, to have a good tear film is very, very important. It is nice to decide whether you're going to be treating your Simplifron along with your SLET, or you're going to be treating it stepwise, and you will be doing a biopsy, going to be doing a procedure which is going to be stepwise. You're going to be treating your Simplifron first, followed by your SLET, or you're going to be doing it together. A B-scan is definitely important in all these cases, and something which is going to go a long ways to do an ASOST preoperatively if you do not have a severe Simplifron, which is going to help you to decide whether you would require a penetrating graft, a penetrating keratoplasty along with it. Sometimes while operating these cases, you can have an underlying thinning of the cornea, and that would mean that an ASOST is going to help you decide whether you need a backup tissue or not. This is a video of a patient which is being operated for SLET. So the biopsy from the better eye is being taken. It is preferred to take limbus or the superior limbus versus any other area of the limbus, which is rich in a lot of limbal stem cells. And what is being done is a blunt dissection up till where you have reached the area of the depth of the tenons. And once tenons is separated and you've reached about 1 mm close to the limbus, the dissection is done using blunt, either you can use a blunt 15 number blade, or you could be using a very clear, using a 15 number blade to get a clear biopsy of about 2 mm. Once the biopsy is taken, you go on to the diseased eye. The biopsy can be kept in a wet mount, or you can keep it on with some amount of fluid for it to prevent from drying. And when you go to the diseased eye, you actually dissect whole of the pannus by doing a superficial keratectomy about 4 mm beyond the defined limbus. And once the pannus is removed with a blunt dissection, while doing this, as I mentioned earlier, in eyes in which you're expecting the cornea to be thin, it's nice to have a backup tissue. The idea is not to reach up the depth of a clear cornea, but to remove the diseased epithelium, which is conjunctivization of the cornea, until you reach a plane wherein you can identify that most of the diseased epithelium has been removed. You cover it with an amniotic membrane, which is spread until you have reached the area of the dissection, and it is stuck with the glue. Once that is done, the biopsy pieces which you had taken from the other eye, which is about 2 mm biopsy, can be cut in about 10 to 12 pieces using either a scissors or using a 50 number blade on a Teflon block. And they are spread over this amniotic membrane, and a BCL is kept, taking care that you do not remove any of this while you're removing your speculum at the end of the surgery. And that's how the eye looks like in the next follow-up days. You are going to see, this is an ASOCT picture of these eyes, when you can actually see the biopsy start producing the cells on the second day itself. And over a period of next 1 week, you usually would see an epithelized surface which has started to come up. And by the day 14, you're going to see most of the surface is epithelized. And if you see the follow-up of these patients, you're going to also see clearing up of the cornea over a period of 1 to 2 years. So looking at the safety of the donor eye, that has been also studied, and it's seen that the donor eye remains very healthy, and you usually do not have a problem of any LSCD developing in those eyes. This is one of the patients which I wanted to show this was one of our first case, in fact, which we had done about 10 years back, wherein a 8-year-old boy had a total limbal stem cell deficiency with a superior symblepharon. And it has a follow-up of about 7-8 years now, and the patient has a 6/9 vision maintaining post-SLET, which was done successfully 6 months later, the deficiency that he had developed. This was a patient wherein had come up after 2 failed procedures of earlier LSCT, which was done, and the patient had had a clot elsewhere. And later on, we did a SLET in this patient, although the eye was amblyopic, but she was extremely happy with also the cosmetic improvement in this eye, which she had gained. Seeing those successful cases, I would just want to mention that you could have patients wherein you have a very deep burn, a very bad limbal stem cell deficiency. They can have a fibrovascular pannus approaching again, and you can have either a small area of failure, or you could have a total area of failure, or sometimes even these eyes can melt if you have a persistent epithelial defect. Hence, the follow-up of these patients becomes very important after the procedure, to look for epithelization, which has to be taken care after any procedure of limbal stem cell transplantation. As I mentioned earlier, these eyes even clear up over a period of time. Hence, seeing up one more slide here, I wanted to show that, just to show that this is a case of partial LSCD in which clot has been done, and after a period of while, you can actually see the limbus, which looks like a limbus has been reformed. So it is actually a beautiful procedure wherein very good results can be obtained in most of the patients. However, you have to take care of the prognostic indicators while you're deciding where you have seen such good results. You need to take care in patients wherein the symblepharon is very severe. You need to decide, one, that you need to take care of the symblepharon before you go on to do a SLET. Second, that you need to decide and tell the patient that the prognosis may not be so good. Also, a simultaneous PK and a need for lamellar keratoplasty should be kept in mind. It will also depend upon the quality of the limbal biopsy that you have taken and from where the surgical interventions have been done. This is one of the patient which a follow-up PK has been done, and we had published our results wherein we had very good results in our patients wherein follow-up PK was done. To summarize, on my last slide, I would just like to say that SLET is most widely done limbal stem cell transplant procedure for today. The results of over 10 years in our follow-up also have given 70 to 80% success rate in terms of the ocular surface epithelialization. The visual outcomes depend upon a lot of other factors in these patients. Combining it with a penetrating keratoplasty or a lamellar transplant is decided by the pre-op anterior segment OCT. And we are still to understand what has been the mechanism of this procedure over a period of time, which is being studied in our center as well. At the end of it, I would just like to thank my team of cornea faculty at SHOF, as well as the limbal stem cell lab with which we work as clinician scientists. Thank you for the opportunity, and I'm open to the questions.
Thank you, Dr. Nidhi, for that wonderful talk. I think SLET, it appears very simple, but as Dr. Nidhi highlighted, you have to remember few practical points to make it a successful surgery. Similar to the previous session, we'll take question if time permits at the end of this corneal surgery part. Our next speaker, I hope ma'am is there. Next speaker is Dr. Tulika Chauhan. Currently, she is practicing in CSF New Delhi. She has experience of working at multiple centers, including UCLA and fellowship from MEI. Her primary interest is ocular surface and corneal surgeries. Recently, she published a nice article about keratopigmentation. So I thought, let's invite ma'am to have this, because this may not be that significant for surgeon point of view, but for patient perspective, it's a very important surgery. So I request ma'am to start her talk. Dr. Tulika, please. In the meantime, any comment from the experts about the Dr. Nidhi's lecture? Okay, she has started. Fine.
Very good evening, everyone. I'm in a different time zone today. So it's the evening in India, and I'm very happy and honored that I've been invited by the DOS team as a speaker. So today I'm going to talk on keratopigmentation, which is commonly used as the word like corneal tattooing. So the first question, just a moment. Yeah. The first question is, why tattooing? Why we need this procedure? So it's a very important thing to do in our practice, because we all are practicing cornea. So we know that how important it is for a surgeon to do tattooing, because we are getting such patients. The indications are normally therapeutic cosmetics, and the cosmetic. These are the three basic indications for tattooing for which we are using this procedure. So the most common thing which we're using in therapeutic and therapeutic cosmetics are the corneal scars, adherent glaucoma, total or partial iris defect, which can be secondary to IS, albinism, aniridia, any large PI, iris atrophies after trauma or anterior segment surgery. Little less common, but yeah, we are using in our day-to-day practice. For example, Urey-Zevalier syndrome, cosmetic change of eye color, which are the cosmetic use are also purely cosmetic use. When we change the color of the eye, we use it for the permanent eyeliners, microblading of eyebrows, and sometimes for the pterygium opacity, and we can use it for the cosmetic reason. So the preoperative considerations are very, very important. We should know that how motivated and how real expectation your patients have. Because if your expectations of the patient expectations are out of the world, then your patient will never be satisfied with this procedure, because so many times the visual potential is nil and we are going to do it for the cosmetic procedure. So patient should be explained. We have to understand what is the motivation of the patient before proceeding with this procedure. And if we understand that, that's the most gratifying procedure for the surgeon. And as we all know, the clinical assessment we are doing before any procedure is like a basic examination, but it can be customized depending upon the etiology. ASOCT, which I feel it is very important, because very thin cornea can result in some kind of complication like corneal perforation. So ASOCT helps us to know whether the cornea is thin or can we proceed with the procedure or not. Systemic investigation is again customized and curtailed according to the patient present health condition, and very important to have a signed informed consent, without which we cannot proceed in any of the procedure. There's no absolute contraindication except for thiazical eye, but in such situation, we should always proceed with caution. If we have any acute ocular inflammation, any NLD blockage, thin cornea, bullous keratopathy, anterior staphyloma, people say that they are relative contraindication, but it depends upon the surgeon and the technique, whether we should go about for the surgery for such indications. Very important to control acute inflammation before proceeding with this procedure, because this one very important complication of this procedure is intractable inflammation post-procedure. So if any acute inflammation is there, we should not proceed. We should treat that first. So there are techniques which are given in the literature, and we must be following so many techniques in this. They usually, one is superficial. They're divided into main two categories, superficial and intrastromal. In superficial, we can go for superficial automated using the tattoo needle, or you can use superficial manual, in which we can use a perforating needle of 26 gauge needle, or we can use any kind of IV catheter which is bent. And these needles can be used for the surface impregnation of the pigments. In intrastromal technique, we can make an interlamellar stromal pocket, which is around 40 to 50% deeper stroma, and we can use it with the crescent, and then we can dissect it with the dissector. And the femtosecond laser can be used to make these intralamellar pockets. This is the pictorial depiction of manual intralamellar KTP we use to create a corneal pocket. The another one is the flap made by the femtosecond laser. And the third one is automated. It is superficial automated because we are using tattoo machine in this to impregnate the dye. So I would like to show two of my cases in which I have made done manual intrastromal impregnation. And that is for the indication. This is a medical student, 22-year-old, peripheral done before ICL procedure. That's a time when the central flow was not FDA approved. So that time the patient was done PI before the ICL procedure. And the moment the PI was done, he has intractable glare. Patient was very unhappy, came for the second opinion. And we did this. We make an intralamellar pocket and we covered the defect with the dye. So the pigment deposition is done with the needle, and we can just wash it out. The only thing is important here, the interlamellar pocket should be equal the size of the defect or a little bigger than the size of the defect so that we can cover the whole defect here. So cosmetically, it looks beautiful and the patient was happy. We can use BCL for the comfort here. Another case which was done with the intralamellar pocket was for the patient had traumatic cataract and hydrolysis. Pupiloplasty was done. Patient came with a lot of glare, dysphotopsia, not very happy with the present situation. So again, we decided to do because the visual access is clear, so we are deciding to do the keratopigmentation for this patient. Interlamellar pocket was bigger than the defect, and the again, it's a manual procedure, and then the pigment deposition was done here. So the aim was to cover the whole iris defect with the dye here. So at the end, the iris defect is totally covered. Patient was comfortable. And then for the comfort, we put a contact lens in this patient. There are a few other pictures I want to show, which are my patients. So just a moment. Yeah. So it's a 20-year-old man with old RD, cosmetically unacceptable leukocoria with nil visual potential. So he was a bit worried that he doesn't want that white reflex to be seen, and he knows that the visual potential is not good. So we did a very small intrastromal pocket in the center, and we impregnated the dye, and the cosmetic results are wonderful. This is 1 month post-op. Yeah. Another case I have is a 55-year young man, childhood trauma, leukomatous corneal opacity with nil visual potential. And the right eye show leukomatous corneal opacity. And this is done by the superficial surface needle impregnation method. And this patient is 2 to 3 weeks post-op in this picture. So cosmetically, he was happy. The result looks fine as compared to his pre-op pictures. The third case is a young man, wooden stick injury, adrenal glaucoma with again, the visual prognosis was not good. And this patient pre-op looks like this. And this is the post-op picture of the patient. And these are my two post-op picture. These are the patients who are not from India, but they just came for the cosmetic correction. And this is the day 1 picture post-surface impregnation. And I would like to show you that what is happening in the world. A lot of colleagues are doing such a wonderful work with the keratopigmentation. The results are very gratifying. These are the results we can, this is the femto pocket made, and there are beautiful cosmetic results we can find. This is the pictures collected from the literature and some of my colleagues who are doing keratopigmentation. And these are the pictures just to show that how beautiful result can be achieved if visual potential is not there and patient really want a cosmetic result. Another slide I want to show you, which shows the gory part of this unregulated tattoo market. These are the pictures which I wanted to show you. In my personal experience, I have seen some patients, though this is not very common in India, but yeah, in Western world, it is very common. This looks very beautiful. People are very happy, but in your clinic, you will not find such happy looking faces. They will come to you with intractable infection and scleral melt. But then it is it's like it's a side effect of unregulated tattoo market, which we should like an availability of tattoo machine and inks everywhere. And it's very common, and this done by all the tattoo artists. Nothing is done by the surgeons. So just wanted to show these slides that these looks beautiful. People are crazy about these things, but they have dreaded complications. So pigment availability, we have in India, we have Mahatme. What we are using in our day-to-day practice is a powder, and then a lot of dyes are available on Amazon, which you can sterilize and use in your practice. There are CE-approved dyes which are usually used in Europe, and that is Biochroma eyes. And in US, there is a Hulk Spalding tattoo supplies which are approved for this. And there are multiple brands which are approved, and they can be used by after sterilization. The dreaded complication, we all know there are many complications because of the sort of time. I just show the slide to you guys, and the most important thing we can avoid by the surgical technique is if it is a very thin cornea. So we should be very cautious not to cause any corneal perforation during surgery, or patient can have recurrent. These are the very common complication what we're getting after such procedure, like intractable inflammation, recurrent erosions, and the fading of dyes, which are very, very common. So these things should be explained to the patient. The good counseling is very important because these patients come with a lot of expectations. Now I would like to conclude my talk that keratopigmentation stood the test of the time and has proved that it can be easily used to offer both therapeutic and cosmetic treatment to the patient with minimal post-operative complication and high patient satisfaction. But the most important thing, the patient selection is very important in such cases. I would like to thank you for having me as a speaker.
Thank you very much, ma'am. If time permits, we'll take questions later on. Now, a corneal surgeon is never complete without knowing the art of penetrating keratoplasty. Our last talk will be dealing with that. And I request Dr. Bhupesh to invite Professor Radhika Tandon, ma'am, for this talk.
Thank you, Professor. So moving to the last talk by Professor Radhika Tandon, and she'll be speaking on the tips of managing pediatric keratoplasty. As we all know that managing kids are always a challenge at home or at clinics or in the OT. So let's listen to ma'am, how she manages these kids with pediatric keratoplasty.
Good evening, everyone. I'm just trying to share my screen. Are the slides visible?
Yes, ma'am.
Okay, so I'll be covering pediatric keratoplasty, trying to give you an insight into certain nuances in terms of case selection and a few tips on surgery, just to give you a kind of a overview of the special considerations in this age group. As you know, childhood is a very critical period for visual development, and consequent to that visual development is also the cognition and the general behavior and the growth of the child. And this is a period which requires special care even in normal circumstances. Even a normal healthy child requires special care. So you can imagine when the child is visually deprived, how much extra is the burden on the family and how much extra care is required after keratoplasty. So it is more difficult for the surgeon as well as the family. And one has to keep in mind that whatever one achieves, ideally we are looking at it lasting a lifetime. So to begin, let us talk a little bit about case selection. It's not as if it's a very easy procedure and as if it can be done in every case with the same expected outcome. So the idea is to restore vision. It may not be perfect vision, but it is going to be appropriate to the disease and also the limitations of additional comorbidities, which I shall be explaining in due course. I'd like to emphasize here that it's not possible to do keratoplasty without a proper collaboration of corneal surgeons and eye bankers. Eventually, we are wanting to, we have to work together to create an ecosystem to eliminate corneal blindness. And the first thing that we can do is take care of the surgically treatable backlog. To emphasize about the special challenges with pediatric keratoplasty, there is an increased risk of rejection with a high failure rate and poorer visual outcome. So it's very important to counsel the family beforehand and also be proactive. So your team needs also to be aware of the special care that has to be taken in terms of follow-up.
One study found that children less than 5 years of
Okay,
age
so this is a recording, so you can listen to
those
that.
Operated in the age group 5 to 12 years, indicating that perhaps one should wait till the age of 5. Another study found that in patients aged 12 years and below, early surgery was not associated with a higher risk of graft failure. This only confirms my point that there is a lot of variation in case selection and also variety of comorbidities and also postoperative care protocols, etc. But needless to say, it is advisable to try to operate as early as possible and practically feasible.
So what are the
There are
basic
several
challenges?
no
We
doubt,
have
in
smaller
operating such
dimensions.
children, and one has to be well prepared for all of them. One important factor is amblyopia therapy, and this cannot be emphasized enough. One requires the cooperation of the parents for this aspect, and counseling, therefore, has to be done accordingly, explaining to them the importance of proper follow-up and post-operative care. So looking at the outcomes and what could be considered a best case scenario, we have this nice study from Wills Eye Hospital Cornea Service where the mean age at time of keratoplasty was about 24 months with a good follow-up duration of about 36 months. Overall mean graft survival was pretty good of 45 months and overall survival rate was 75%. But please note that the study had shown that the 1-year graft survival rate was considerably poorer in eyes with glaucoma, and patients able to achieve ambulatory vision in the last follow-up was about only 50%.
So now coming to
one
what we
should
have
make
achieved
every
is
effort
very
in the
important.
preoperative assessment to see if one can do a lamellar procedure rather than a full thickness PK.
So talking about comorbidities, as I mentioned, glaucoma is important, but if you take proper care of these children, one can have very good results with clear grafts, even with poor prognosis cases, such as trauma. Keratoconus, of course, is a better prognosis and other developmental abnormalities. The other important thing I'd like to emphasize, it's not only doing the surgery, but one has to be aware about restoration of vision and binocularity. So one has to, it can be quite challenging to document the vision in a very small child. So after the surgery, you have to keep in mind that you have to do repeated refraction, prescription of spectacles, and appropriate occlusion. So now to give you a few surgical tips, you have this child who is being operated. The child had keratomalacia and post-keratomalacia sequelae of a bilateral, very densely leukomatous corneal opacity, heavily vascularized. I'm using a Fleringa ring and I like to do the debulking technique in such cases because it makes the dissection a little bit easier. You can see that the lens is cataractous, the lens is removed, and the graft is put in place. I like to do a 1 millimeter oversized graft in such cases because there's less post-PK glaucoma, less peripheral anterior synechia, and a deeper anterior chamber. I like to put a bandage contact lens on the table, and then I repeat the EOA after a week, at which time the bandage contact lens is removed, and usually there is no epithelial defect. So the child is much more comfortable, and there is less discomfort from the initial epithelial defect that is commonly occurs after penetrating keratoplasty. Giving you another example of a child, this is the anterior segment dysgenesis. Often these children have a limbal stem cell deficiency, or they have a more anterior limbus. So therefore, you mark the center and you see if you're able to do a 7 millimeter host cut without damaging the limbal stem cells. If not, then you would like to retract the limbal stem cells and spare the limbus to retain the palisades of Vogt. The ASOCT can help by identifying the nature of the opacity. Even UBM is often done if there's absolutely no visibility. It helps to identify. So as you can see, when I made my circle of 7 millimeters, it was impinging on the limbal stem cells. So therefore, I have retracted the conjunctiva to try to retain the cells so that we do not end up with a persistent epithelial defect after surgery. The Fleringa ring helps because children have very low scleral rigidity, and there is a tendency for the globe to collapse and increases the vitreous pressure. Often a very clear lens may even spontaneously extrude. So to avoid that, it's useful to put a Fleringa ring. And so once you've marked it out, you'd of course like to have, as far as possible, a healthy donor as close to the age of the child as possible. Usually we try within 10 years. So if it's a 2-year-old child, we'd like to have a cornea of a donor who's less than 20 years old, and so on. One can put a mark for to guide your sutures using RK marker. It's not mandatory, but it can be useful. And then you can do your central trephination. One could use a manual disposable trephine. One can even use a Hesburgh-Barron trephine, depending on the case. As you can see, in this case, it's also very opaque. So I will try to use a debulking technique. The benefit of that is that you reduce the thickness of the donor cornea that you're using. So in case there are iridocorneal adhesions, it's reducing the pull on the iris. You're able to dissect the tissue better without producing any damage to the underlying iris. Plus, when you do a lamellar dissection initially, you can sometimes find a relatively clear area where you can start to see into the anterior chamber, and you can enter in a more controlled fashion and avoid hitting the underlying lens or iris. Sometimes such patients also have aniridia, and often there may be the exposed lens underneath. So that's another benefit of doing the debulking technique. In this particular case, after the initial entry, I have injected the cohesive viscoelastic. As you can see here, there is a pristine anterior segment. Fortunately, there is no damage to the iris, or the underlying lens is also clear. And so we're removing the rest of the host cornea. And I'd like to say that it is important to tell the anesthetist that we do not want the patient's eye to move, and also would not like to have an increased pressure. So therefore, we'll encourage them to give a mannitol at the time of induction, and make sure that they give adequate muscle relaxant so there's no movement of the eye muscles, which is increasing the positive vitreous pressure. Then apply a dispersive viscoelastic. The donor cornea I have already prepared beforehand so that we minimize the open sky time. Making a small PI in this case. I don't always do a PI. Confirming that the PI is patent. Checking that the angles are open and that there are no adhesions, and then the donor cornea is sutured in place. So 4 cardinal sutures, and after 8 sutures, we'll remove the viscoelastic using bimanual IA. And then complete the surgery, make sure the knots are well buried. And also make sure that the tail of the suture is properly buried, because as the donor cornea loses its edematous state, sometimes the tip of the tail of the suture may stick out. So it's very important to make sure it's thoroughly buried. Replacing the limbal stem cells as they were, and put a bandaged contact lens and topical moxifloxacin drops and a subconj injection. And the EUA would be done after a week, at which time this bandaged contact lens will be removed. It will confirm the intraocular pressure. So overall, one can have good results of keratoplasty. One has to be very proactive and follow up.
I hope you enjoyed the talk.
Yeah, and I'd like to thank all the faculty and residents who help in taking care of the patients, as well as the staff in the National Eye Bank. I shall stop here. I have 2 examples of cases, but I think more or less we can have good results with a variety of types of surgeries. We can do DALC, and this is the case of Peters Plus syndrome after 10 years follow-up.
So one can have very...
Thank you, ma'am. Thank you so much. It was a wonderful talk, and we learned so much from your talk. So as you've worked a lot on keratoprosthesis at more fields, so what is your take on using keratoprosthesis in all these cases of multiple graft failure in pediatric patients? Do you recommend keratoprosthesis?
I'm not very keen on keratoprosthesis in children. Of course, keratoprosthesis has been recommended even in patients with aniridia and poor prognosis. The trouble with keratoprosthesis is that there is a risk of melting, and it's a question of, as far as survival goes, the survival of most devices is not more than 10 or 15 years. That's the longest. And if you think of a small child who's less than 10 years old, you would like that cornea, at least take that child to the age of 60 or 70. So therefore, I would say that we have to be very cautious, and it is better to do a keratoplasty, very careful follow-up, rather than go straight for a keratoprosthesis. Because with the keratoprosthesis, if you don't have any prompt intervention, in case of the slightest chance of a complication, you can completely lose the eye, which rarely happens with a keratoplasty, unless of course there is a graft dehiscence. Often they are prone to trauma, and they can come with a complete, wound dehiscence and all those complications as well. So it's very important to explain to the parents that you must come back promptly, and preferably within 24 to 48 hours at the slightest indication of any redness or any abnormality. The other thing I forgot to mention is that early suture removal. In pediatric cases, you don't have to wait 1 year. You can remove the sutures as early as 3 to 4 and even 6 months after surgery, depending upon the age of the child.
That was the next question. So in pediatric patients, suture removal is always a challenge, whether to remove all the sutures in one go, because you have to take anesthesia every time. So how you plan? 3 months or 6 months all sutures in one go, or you remove half, then after 3 months?
Usually what we do is we generally start at about 4 months. Obviously, if there's a loose suture, you remove it straight away. But if you're doing an elective suture removal, do alternate suture removal and watch how the graft behaves. And if it's absolutely stable, we do remove all sutures at one go.
Okay. Thank you, ma'am. Thank you so much. Any panelists?
And how long you continue the steroids post-op?
Oh, yeah. So steroids, in children, frequent steroids for the first 1 month, and then you reduce to 3 times a day for 3 months. And after that, slowly taper up to the age of 1 year. After 1 year, you continue topical steroid once a day.
Okay. And do you give oral also?
Sorry?
Oral steroids?
Oral steroids, some very high-risk cases, sometimes we would give a short course of oral steroids, but otherwise we prefer to use more topical steroids, and we also use topical tacrolimus on the lids 3 times a day. It has been shown to be as good as systemic tacrolimus. So oral steroids very, very rarely, unless there's a lot of handling of the iris. And then if you give the oral steroids, it is only given for a week. And the anesthetist does give an IV shot of Decadron during the anesthesia. They do it for their own purpose, and that helps us as well.
Right.
And how much is the incidence of post-PK glaucoma in this pediatric age group?
Yeah. So firstly, a lot of the patients have glaucoma per se. So they may be congenital glaucoma who have got undergo keratoplasty, or they may be anterior segment dysgenesis with secondary glaucoma. And say it's a routine case like a trauma or traumatic scar or heel keratitis, no glaucoma, and then they go for surgery. So we've been able to reduce the incidence of post-PK glaucoma by oversizing the grafts. 0.75 or 1 millimeter oversize reduces the post-PK glaucoma by almost 30 to 50%. But it is a very, very common complication, and so one has to work with the glaucoma specialists and keep watching out for the rise in intraocular pressure.
True.
Thank you very much, ma'am, for that wonderful talk. I think we all at RP Center have learned eye banking, cornea transplant from ma'am only. In fact, she's my first triple procedure was assisted by ma'am only. So with this, I think, Bhupesh, we have come to the conclusion of our session, all the 3 sessions. Now I hand it over to Secretary and President, sir, to conclude. And
I think we've had wonderful sessions of all the wonderful 3 sessions, both on keratitis, corneal anesthesia, and corneal surgeries, and wonderful talks by all the speakers. They did wonderful job. Dr. Ritu Arora, Dr. Tityal, Dr. Rajesh Sinha, Dr. Namrata, Dr. Nidhi, Dr. Tulika, Dr. Radhika Tandon. Everyone, the talk was very illustrative, and we are also thankful to our panelists, Dr. Rishi Mohan, Dr. Rajiv, and congratulations to our young moderators, Dr. Praful and Dr. Bhupesh, for really conducting the whole cornea session so nicely. I'll hand it over to Dr. Jitendra Prasad for his final comments.
Thank you, everyone, and thank you, audience, for being with us in this late evening. And I really thank Praful and Bhupesh for making such a beautiful program of corneal diseases. I think I first time I've attended the cornea session, and it was so wonderful, like a talk by so many big shots, and especially Rajesh, Dr. Tityal, and Dr. Namrata, Dr. Radhika, Dr. Vanathi. So really, it was a really interesting and enriching to all of us, especially the basics of corneal diseases and how to treat the infections and all these things. So thank you very much, all the speakers and panelists and our young moderators. Thank you very much, and we see you next time soon. And our next episode is going to be on the retina. So probably this month we have the retinal diseases web series, and thank you very much.
Thank you.
Thank you, DOS, and DOS President, Secretary, and Praful and Bhupesh, everyone.
Thank you, sir. Thank you so much, sir. Thank you, sir.
Thank you, sir.